Hello, and welcome to my lecture on a chronic obstructive pulmonary disease, also known as COPD. My name is Chelsea Hartigan, and I'm here to take you through this lecture. By the end of this lecture, the student will be able to understand and reiterate the following about COPD: the pathophysiology, etiology, clinical manifestations, laboratory findings, and their medications and side effects, which are very important with COPD. So what is COPD? COPD is a common and preventable respiratory disease with the narrowing of airways. So there are two common types. So there's emphysema, which is the loss of lung elasticity and hyperinflation of the lungs, which results in dyspnea and a need for an increased respiratory rate. And then we have chronic bronchitis. Chronic bronchitis is when you have the inflammation of the bronchi and bronchioles in the lungs that are caused by exposure to irritants. This does increase mucus glands, which the patient with COPD and chronic bronchitis is going to have a large amount of thick mucus. To be considered chronic, this has to occur for at least 3 months of the year for at least 2 consecutive years. Of course, if you think about it, our lungs aren't working properly, so our oxygen level is probably going to decrease, which allows, unfortunately, our CO2 level will increase. So this may lead to respiratory acidosis. COPD, unfortunately, is the 4th leading cause of morbidity and mortality in the United States. There are 14 million adults who are affected in the U.S. with COPD. Like I said, COPD has 2 types, chronic bronchitis and emphysema. And the pathophysiology behind this is when we end up being exposed to tobacco smoke, harmful substances, vapes, irritants, then it causes irritation in the lungs. And what happens is your body releases immune cells, such as the cytokines, neutrophils, macrophages, lymphocytes, and they're trying to fight the damage that's being done in your lungs. However, when you continue being exposed to this irritation and inflammation, this can lead to the chronic bronchitis. While this is occurring at the same time, you have increased protease activity. So protease is an enzyme which breaks down tissue in the lungs, so it becomes less stretchy, which makes it harder to breathe. So this is what emphysema is. This all leads to airway obstruction, air trapping, loss of surface area for gas exchange. So, of course, what do you think are some main risk factors for COPD? Of course, tobacco smoke is number 1. So this might include cigarettes, pipes, cigar, environmental tobacco smoke. So if you grew up with a smoker, this might you might be at higher risk for developing this. Occupational dust and chemicals. So these are our vapors, irritants, and fumes. Indoor air pollution. So this might include fuel that might be used for cooking and heating. So that's why it's very important for these places to have very good ventilated areas. COPD, you can be at risk for it if you had any factor that affects lung growth during gestation and childhood, so low birth weight or respiratory tract infections. And also it has a genetic component as a risk factor. So if you have a mutation of the alpha antitrypsin gene, this can result in the development of COPD at an early age, even if these patients don't smoke. So how are we going to assess our patient with COPD? So what's the first thing we're going to do? Of course, it's always important to ask about personal history. So make sure to explain to them that if you've been exposed to smoking, if you've been a smoker, you currently are smoking, that obviously can put you at higher risk for COPD. Ask them about their breathing problems. So is it difficult to breathe while they're talking? Are they able to speak in complete sentences? Are they noticing wheezing, coughing, and shortness of breath? Ask them if they have the exposure to pollutants. Ask them about their activity level. So have they noticed a decrease in their activity level? Because of course, if they're not able to breathe appropriately, they're not going to be able to do as many things. So maybe compare the activity level and shortness of breath from 1 year ago to when you're assessing them. Of course, we know that we're going to do our regular respiratory assessment. So this includes inspecting, palpation, percussion, and auscultation as well. You might see these patients sit in a forward bending posture with arms held forward, so either on a table or maybe their hands on their knees bent over. This is called the tripod position. These patients might obviously be slow moving. You might notice loss of muscle in the extremities. They're going to have dyspnea, so they're going to have trouble breathing for sure. It's going to be noticeable. They'll probably have a cough. They'll have wheezing. They'll have prolonged expiration as well. You might see fatigue. You might see central cyanosis, digital clubbing. All these kind of point to COPD. You definitely, with patients with breathing problems, you want to definitely look at their psychosocial assessment, because imagine going from being able to be in a quiet environment such as like a movie theater or a church, and you can't get up the stairs properly, you're having to cough all the time. That can be very embarrassing. So you want to be able to assess if they're embarrassed from coughing, if they have an anxiety from being breathless. Also, you might want to inquire about their economic status, because these medications that are used to treat this can be very expensive. Here I have a picture of chronic bronchitis versus emphysema. So what are our patients going to look like? So our chronic bronchitis patients are going to look overweight, cyanotic. That's our blue bloater, as we have here on the left. So then we have elevated hemoglobin with these patients. They might have peripheral edema, so swelling in the extremities. And you're going to hear that rhonchi and wheezing with these patients. Then we have our patients who may have emphysema. So these are going to be our older, they're going to look thin, they're going to have severe dyspnea, so they're going to have extreme problems breathing. They're going to have a quiet chest though. You're not going to really hear as much, but you will be able to see on an x-ray that hyperinflation that we talked about. And this is our pink puffer. Lab findings for COPD. So of course we're going to start with our physical exam. That's going to be our best way to be able to see the symptoms that we can hear and see with a patient with COPD. You might see a doctor, or you order a chest imaging. You might do pulmonary function tests. So this is used to diagnose, stage, and monitor COPD. So how they do that is they have spirometry is performed before and after administering a bronchodilator. A ratio of the forced expiratory volume in 1 second is compared to the forced vital capacity. And if it's less than 0.7, that confirms COPD. You might do blood gas analysis, sputum cultures. Of course, hemoglobin and hematocrit can never hurt with these patients as well. So what do you think our treatment? What's our main goal for COPD? Of course, this is going to include improving that gas exchange, trying to get that CO2 from being retained in the body. That's going to be our main goal. Improve nutrition. So of course, if we have one of our overweight patients, try to have them have weight loss. If we have a patient who is very thin because they've got emphysema and they're very thin, maybe improve that nutrition so they don't lose too much weight. Try to improve their quality of life, because of course their life could be changing, or if they're dealing with it for a long time, they might feel like they can't have a quality of life, but we can maybe try to give that to them. And then try to reduce exacerbations and mortality, because remember I said that this is the 4th leading cause of death in the United States. So what's going to be our treatment for COPD? Oxygen, of course, can be prescribed for patients with COPD, for patients with severe hypoxemia. So of course we would want to assess that. Bronchodilators are going to be our medications that help open up those airways. So these are our beta-2 agonists, or short-acting beta agonists such as albuterol, or long-acting beta agonists. antimuscarinics, and methylxanthines. The side effects of these medications include tremors, nervousness, sudden and noticeable heart palpitations, and muscle cramps. So your typical side effects with respiratory medications. We have a selective phosphodiesterase 4 inhibitors, such as roflumilast. And this medication, what it's used is to help prevent flare-ups of COPD. So this is to help, like I said, prevent it, not stop it once it's started. These medications have side effects as well. So it might be unexplained weight loss, cough, diarrhea, and the worst one probably would be thoughts of suicide. And of course, if we have any indication that a patient says they want to end it all, they want to end their life, that of course we want to be able to notify the provider as well as suggest that they stop the medication if they can, or change it depending on exactly what's going on, because we do not want them to continue to have these thoughts. We have mucolytics, which thin that mucus secretions that you see with those chronic bronchitis patients. And of course, inhaled corticosteroids. So this reduces inflammation in the lungs. So the side effects of these, obviously if they're inhaled, it's going to be like thrush, a sore throat, tremors, and heart palpitations as well. So here's a quick summary of our information that the main points we need to take away from this lecture. So we need to know that COPD is a chronic inflammation in the lungs and causes reduced airflow. There are two common types, chronic bronchitis and emphysema. So remember our blue bloater and our pink puffer. Smoking and pollutant exposure are main risk factors. We have our main signs and symptoms, our dyspnea, productive cough, prolonged expiration. Medications are going to be very important with these patients, so make sure that they are taking them appropriately. Oxygen is sometimes going to be necessary, and then of course remember our main goal is try to improve that gas exchange. So here I have a question regarding some of the medications that we went over. So we have a patient with COPD who is reporting depression and thoughts of suicide. The patient states, "I just feel like ending it all." You assess the patient's health history and note that the patient was recently started on which medication that could cause this side effect. Symbicort, prednisone, roflumilast, or theophylline. So which one do you think applies to this situation? Yes, so the answer is going to be C, roflumilast. We did discuss about that in our medication slide. So roflumilast is a selective phosphodiesterase 4 inhibitor that is used to prevent COPD flare-ups. Like I said, its side effects can include unexplained weight loss, cough, diarrhea, and thoughts of suicide. So it's very important to monitor these patients that are on this medication for those thoughts of suicide. Here's my list of references that I used for this PowerPoint, and I hope you enjoyed your lecture on COPD.